Hi, I'm Daneshmand from USC, University of Southern California in Los Angeles, and it's a pleasure to be here today. On my first talk, I'll be talking about the role of microRNA in the future management of testicular cancer. I'm professor of urology and director of urologic oncology at USC. I don't have any disclosures to this relevant to this talk. So generalized management, this is my view. Most of stage one germ cell tumors, whether it's seminoma or non-seminoma, we advocate surveillance for most of these patients. In 2A, non-seminomas and recently in seminomas, I strongly prefer RPLND to avoid the long-term toxicities. And in greater than 2B, 2B or higher stages, we prefer chemotherapy plus minus response-directed post-chemo RPLND. So here's a timeline of major advances for germ cell tumors. We have cisplatin-based chemotherapy that came along in 1975, and then the duration and intensity of the treatment was shortened from 2 years back then to about 12 weeks. And etoposide then was found to be equally effective, less toxic in the late 80s. Then there was a risk-adapted duration of BEP 3 versus 4. And in the mid 90s, we had salvage chemotherapy curing half of the patients with recurrent disease. But since then, really, there haven't been too many major advances. Of course, there have been surgical advances and a decrease in the morbidity of the surgery, but everything's been incremental improvements now in the delivery of care, the shift in emphasis to quality and survivorship. So there's still a fair bit of uncertainty in the management of germ cell tumors. We have starting with the testicular mass. Is it germ cell tumor to begin with? Do we need to do an orchiectomy when you have normal markers? We have false positive marker elevation or very small radiographic abnormalities. In clinical stage 1 disease, is there a microscopic disease? Do we need to do an RPLND? Leads to frequent CT scans and sometimes adjuvant therapies that are not really needed. So what about 2A, relapse, unnecessary treatments, biopsies, and then in the post-chemo, post-primary RPLND, do we need adjuvant therapy? Is the patient cured with our surgery? And then in the post-chemotherapy setting, with the residual mass, does it harbor viable germ cell tumor? Is this all necrosis or teratoma? Certainly, again, there's a lot of uncertainties that we haven't really made much advance in. So now we have these microRNAs in germ cell tumors. And what are these microRNAs? Basically, they're small, about 22 nucleotides of non-coding regulatory oncogenes and oncosuppressor transcription genes. So basically, you have the microRNA gene, and you can see that it goes into the nucleus and goes into the microRNA and forms a duplex, forms mature microRNA, and there's translational repression and then degradation, and it affects the toll-like receptor ligands within the cell. So in germ cell tumors, there's oncogenic mutations, as we know, and this work really was done by Verheven in 2016. And what happened with these studies is there was a discovery of a cluster of these microRNAs that are very, very well preserved in germ cell tumors and overexpressed and extremely specific to germ cell tumors. There are other microRNAs that are specific to other tumor types as well, but this 371 cluster was shown essentially in 4 different studies starting in 2007 to be overly expressed in germ cell tumors, whether it was seminoma or non-seminoma. So it's the 371 cluster and the 302 cluster, but really 371 has been one that has been the most high fidelity marker that we have. It's released in the bloodstream. It's stable for months. They're detectable even in the GCNIS, the germ cell neoplasia in situ pre-surgery in a patient with metastatic disease. It is proportional to the tumor burden. So you can see here, sorry, let me go back. In the inflammatory stage, this is microRNA 373. You have little in terms of markers in stage 1, you have more, and anything more in stage 1, you have a lot more. So it is proportional to the tumor volume as well. And this was shown as early as 2013. They are repeatable and reproducible between different centers as far as we know, although there needs to be more work done in this regard. So what about when you compare the microRNA 371 versus CT versus tumor markers? You can see the AUC here in terms of specificity and sensitivity is really high. We barely ever see these curves. This is not even a curve. This is a line. AUC is 0.97. With CT scans, it's 0.77. There are uncertainties in CT scans where we have findings on CT that may not be real, or we have occult disease that we just don't see. And even with tumor markers, we can have elevations of tumor markers that are not very specific, and some tumors don't produce markers, as we all know. So these microRNA are far more sensitive and specific than CT or markers. They are detected in very small volume of serum and plasma. It's quantified by real-time PCR, and the extraction kit as well as the reagents are commercially available, but the test itself is not available. The estimated cost will be somewhere around $60. This is going to be a cheap test in the future. So when you look at the microRNA operating characteristics, there are these 5 studies that looked at 3 retrospective and 2 prospective studies looking at the microRNA sensitivity and specificity, the operating characteristics in various stages of disease. In the first study, you can see in 2017, 250 patients, this is primary tumor pre-orchiectomy, sensitivity for finding germ cell tumor, 90%, specificity of 86%, positive predictive value of 94%. In Liao et al. In 2017 looked at 82 patients in the post-chemo residual disease, one of the areas we're really interested in. And you see the sensitivity of finding viable germ cell tumor was 100%. Negative predictive value was also 100%. The specificity was 54%. For the metastatic pediatric extracranial malignant germ cell tumors, only 5 patients, but again, the specificity you see was 100%. Lucia Nappi and Christian Kohlmansberger from University of British Columbia in 2019 looked at prospectively at 132 patients in various stages of disease, clinical stage 1 on surveillance, relapse patients, metastatic patients, and 19-month follow-up. And you can see again, the specificity was 100% with positive predictive value of 100%. And then in a prospective study with 616 patients with Diekman, who's really been instrumental in our understanding of microRNAs, showed a specificity of 94% in the pre-orchiectomy setting and metastatic prior to and during chemotherapy. So again, you can see the really high fidelity characteristics of this marker. Now, in Nappi's study that was published in JCO in August of 2019, there were 3 patients who were microRNA negative and were found to have tumor. But let's look closely at these patients. One of them had retroperitoneal biopsy showing follicular lymphoma. So that was true to the not having germ cell tumor. In the second patient, the patient had a very high LDH and had teratoma, and RPLND showed transformed teratoma. So the microRNA was negative, but again, these are very specific for germ cell tumors, and you have a somatic transformation here. It's not going to pick that up. And then the last patient had an AFP of 13, a microRNA negative, but you can see this was fibrosis and had a mediastinal mass with an AFP of 16, which is slightly elevated, but the mediastinal mass resection showed fibrosis. So again, even in the patients who were microRNA negative, this test performed really well. Looking at patients in the metastatic disease, but not in teratomas, you can see that there were only 2 false negatives here, with all patients who had no evidence of germ cell tumor falling below this line. So you can clearly demarcate and draw a sharp line between the patients who are positive and negative. And again, this is the ROC curve showing the specificity and sensitivity. When you put in the CT scans and the tumor markers, they're nowhere near as high as the ROC curve for the microRNA. So again, we're beginning to see this picture of repeated studies showing you the same thing. So now we're moving on to clinical trials, and there's one clinical trial currently open the SWOG S1823, which is all newly diagnosed germ cell tumors, age 18 or more, all seminomas. More than 90% of non-seminomas, basically, they get a serum drawn at the time of diagnosis, and they're followed. And this is just basically a registrational study, and the patients are not, patients or the providers are not provided the information on whether it was positive or negative. So 1,000 patients are due to be enrolled in this study. There's another study very similar to it, the AGCT 1531, which is age for pediatric patients and those with ovarian or extragonadal germ cell tumors. Let's look at these a little bit more closely. These basically just started. We've started accruing to these 5-year expected enrollment of approximately 1,000 patients. It's just basically, again, an observational cohort looking at microRNA in newly diagnosed germ cell tumors. And the primary outcome is really to see the positive predictive value of microRNA in the real world setting in a prospective blinded fashion. So all the inclusion criteria is anyone with newly diagnosed germ cell tumor, all primary sites, stages, histological subtypes. We just want to gather as much information as possible. Very easy to do. We draw them on something called a Streck tube, and these tubes are shipped centrally and kept centrally, but the patients are followed, and repeat labs are drawn, repeat microRNAs are drawn according to the tumor status, their risk status. And the AGCT 1531 is very similar, but this is a multi-center randomized open label clinical trial, 2,059 patients. That's a very, very ambitious trial. It's expected to take about 10 years and has these 5 arms of patients getting either BEP times 4 with cisplatin or carbo, and the various, you can see the different arms here, and active surveillance for stage 1 germ cell tumor. So their primary outcome is 2-year overall survival and 2-year event-free survival, with a bunch of secondary outcomes looking at side effects. So now we're moving into the next phase. We are working on a trial concept in stage 2 germ cell tumors. As you may know, I just completed the multi-institutional SEMS study, the SEMS surgery in early metastatic seminoma, that showed approximately 80% of patients were disease-free following RPLND for stage 2 seminomas. Well, now we're moving on and doing the next trial, which would be suspected regional disease. That's early stage 2 disease. If the patients have less than 3 centimeter normal or low stable markers, they get a qualitative microRNA, positive or negative, and they would move on to either primary RPLND if they're positive, or if they're negative, then they would have a period of observation with reassessment and re-imaging, and then followed with CTs. Those with persistent markers perhaps would be eligible to get adjuvant chemotherapy. This is not the final trial design. This is just one of the concepts that we're putting through. If the patients have more than 3 centimeter tumor definitive markers, we do draw this 371, but those patients, as per current standards, would get 3 cycles of BEP for good risk disease, or times 4 for poor risk disease. And again, we would measure serial markers. All the RPLNDs are going to be performed in certified centers of excellence within the United States, just like they were in the SEMS study. We estimate probably somewhere in the 150 patient range for this to be able to answer some of these questions of whether microRNA will be useful in helping us decide whether these patients should undergo primary RPLND. The reason for this observation period is in our trial, and as we know in non-seminomatous germ cell tumors, that 20 to 30% of patients in some studies actually up to 40% of non-seminomas with clinical stage 2 disease actually have pathological stage 1 disease. So that's why if we can see if these patients are microRNA 371 negative, then perhaps we can have a period of observation, and maybe that lymph node is a benign lymph node that will go away with time. And we see this clinically as well. There's no need to rush into treatment when you have a lymph node that's only 2 centimeters. So hopefully this will roll out soon. We are looking for funding and finalizing the concept. But again, this is just in concept. We have not started the trial yet. So as far as future studies, I think we're moving closer towards personalized medicine. I think in the future, we're going to have microRNA-directed management of clinical stage 2, as well as post-chemotherapy setting. The biggest challenge in the post-chemo setting is the teratoma. What are we going to do with the residual mass that's 2 centimeters? Current guidelines are that if we have anything over 1 centimeter, we would be recommending a post-chemo RPLND. So because we're looking for teratoma. However, we know that as the size of the residual mass increases, the higher the chance of it having residual teratoma or viable germ cell tumor. And perhaps these microRNA 371 can reassure us that we don't have viable germ cell tumor, but rather perhaps teratoma. And perhaps we could have, again, an observational period for the slightly smaller masses to see if on subsequent CTs, they end up getting slightly smaller. So again, I think it's exciting times in the next 10 years or so. We're going to have a number of studies coming out clinically that are going to help us guide better and more personalized treatment. So again, in conclusion, these are useful biomarkers. They're clinically validated across multiple stages. They're extremely accurate, extremely high sensitivity and specificity that we haven't really seen from any marker. And we're planning these large clinical trials to validate their utility. So with that, I'll stop. Thank you very much.